Morning, colleagues. I'm hoping you can hear me clearly. My name's Michael Kellet, and I'm going to chair this morning's Putting Learning into Practice session. I'm really grateful for everybody who's joined. I'm the Director of Strategy, Governance and Performance in Public Health Scotland. I've been asked to chair the session today. So let me warmly welcome all of you. Really looking forward to the discussion today, hosted by Public Health Scotland. I won't say much. You're not here to hear from me today, but let me just provide a little context. I hope you know that in Public Health Scotland, we are working in partnership determined to improve the health of Scotland's people. We are very clearly focused on improving healthy life expectancy and driving down health inequalities. And let me just give you one stat today that exemplifies the scale. Healthy life expectancy for those males who live in our poorest communities at the moment in Scotland is 44.9 years. It's over 70 in our most prosperous communities. That's a difference of 26 years in healthy life between males who live in our most deprived communities and those who live in our most prosperous. We know in Public Health Scotland that we can only, as a society working together, tackle these problems. We also know that we need to tackle the wider social determinants of health and have a step change and a shift towards prevention. As I said, we can't do that alone. We recognise we need to work collaboratively with others across our communities, across public services, across local and national government, with the third sector, with business too, to bring focus and effort to what matters most, to improving our population's health and reducing those health inequalities that stat exemplifies. And the purpose of today's panel is to get into those issues, to raise awareness of health inequalities in Scotland, and really importantly, and most importantly, to consider what we can do to tackle them. And I'm really delighted to welcome our panel members who will share their wealth of experience and support us to do that, to deepen our understanding of health inequalities and to focus on what we can do, what action we can take to reduce those health inequalities. The panel will share their views, their insights, their experience of measures already taken, and also what more we can do to make a difference. And as you listen to the discussion, please have a think about questions and put questions in the Q&A function. And we have colleagues behind the scene who will be helping kind of moderate and select the questions, and we'll come on to that discussion in response to your questions in due course. And the last thing I want to say by way of introduction before moving to introduce the panel was just to say, as it's probably obvious to you, the panel session will be recorded and we'll make it available hopefully fairly soon for others to view as well and to share the learning. So let me very briefly introduce the panel members and thank them. We were having a bit of a technical issue, folks, as we set up the meeting this morning. So at the moment, unless somebody tells me otherwise, we've got 3 of the 4 panel members we anticipated having with us in the kind of panel that you'll see shortly, but we're working hard behind the scenes to get the other panel member with us. So I'm confident we do have Professor Donna Hall with us. Donna has been described as a public service pioneer by Andy Burnham, the Mayor of Greater Manchester. As many of you will know, I'm sure she was the CEO of Wigan Council for 8 years and developed the Wigan Deal, that very new dynamic relationship with the residents and the people of those communities. And she did similar work as CEO of Chorley Council as well. Donna, you might tell me I've got the pronunciation wrong there. Donna was appointed the Honorary Professor of Politics at the University of Manchester in August 2019, and she's also an Integrated Care Advisor to NHS England. So Donna, thanks for joining us and bringing your experience and wisdom. And in no particular order, next we have Dr. Carey Lunan. Many of you will know Carey. She's worked as an NHS GP for 20 years, mostly in areas of high socioeconomic deprivation. She is chair of the Scottish Deep End GP project, which, as you'll know, works in the 100 practices serving the most deprived communities in Scotland. Carey's an honorary senior clinical lecturer at Edinburgh University. She's currently on secondment from her clinical work as a senior medical advisor in Scottish Government on health inequalities and mental health. And Carey was chair of the RCGP in Scotland from 2017 to 2019. We also have on the call, on the panel, Professor Gabe Docherty. Again, many of you will know Gabe. He retired as the Director of Public Health in NHS Lanarkshire in 2022. Gabe played a really important role chairing the Directors of Public Health group during the first year of the pandemic. But more broadly, Gabe, in his work in Lanarkshire, led the development of a strategic partnership with the University of South Clyde, with the key aim of developing innovative approaches to addressing health inequality. And Gabe has championed efforts to address health inequalities right the way throughout his career. The person we're desperately trying to get to join the panel so we can hear from her later is Susan Paxton. And Susan, you may be hearing this as an attendee. We're doing our level best to get you in as a panel member, so please bear with us, and my apologies. Susan has worked in community development for over 30 years and is really passionate about social justice and equality and equity, and she is director of the Scottish Community Development Centre. She leads that staff team to support communities to be strong and sustainable for a more just and equal society. So a really impressive panel here today. Hopefully the technical glitches will get us through, and what I will then do, and if the panel want to say anything more by way of introduction, I'm very happy for you to do that. But we've got a number of questions that we've asked the panel to think about to really start our thinking, and I'm going to start with a question to Gabe, which Gabe, moving to you, the question, as you know, that we've asked you to think about is, in what ways can public services be tailored to address the unique challenges faced by the most deprived communities across Scotland? Gabe, over to you.
Yeah, thanks, Michael, and good morning to everyone. Yeah, I'm actually getting some flashbacks to the pandemic here, because the only difference is I'm actually seeing smiling faces on the screen. And then the other thing, actually, I've got a hot cup of tea as opposed to a cold cup of tea, so it's lovely to see everyone from there. Michael, it's a really good question to start off with, and I suppose the first thing I'd really like to focus on is we talk about communities, and immediately we think of a geographical area or people of community, a community of interest. But one of the things I like to throw out there, and hopefully might raise some comments in the chat, is basically the kind of, how do we identify persons who don't fit into any specific group? I'd love for us all just actually to sit down and get all our education colleagues, police colleagues, and everything else, and actually say, who have you got who's got the most concerns for you, and how can we collectively actually look to address them? So I'll put that one out there. So we're talking about, it's just not about communities, it's about people. And when you use data zones, for example, we'll lose a whole lot of people in very affluent data zones. That's the first one, I like to think of. I suppose in terms of actually the specific, question, basically, the younger me are actually saying with public services, I'd be saying okay, let's train staff, let's get them focused on brief interventions, let's do this, let's do that, let's do this. However, the older me is basically saying there's three things I really want to focus on. The first one is really pushing the whole issue of compassion. And the reason I'm saying this is it was Falls Action North Lanarkshire at a conference. There was a very, very senior retired civil servant, and he talked at the NHS. And I apologise, I don't know the local authority system, well enough, and the other systems well enough. But he talked at the NHS. This is about 10 years ago, and he basically said, "Listen, I've studied healthcare systems across the world. The NHS is ruthlessly effective and efficient. However, there's one big but to that. He says you've got to comply. If you don't comply, the NHS has not been set up for you." right? So just hold that thought from there. Second one, these leadership things where you kind of like sent out to work in people's, shoes, basically. And I was kind of like sent out to work with the homeless team, the NHS homeless team in Lanarkshire. Brilliant team of people. And see, my observation at the end of the day, I actually said to them, do you realise that you spend at least 50% of your time pleading and negotiating with fellow clinicians to reappoint a homeless person who hasn't turned up for an appointment? So there's that whole issue of compassion and what are we here for? And it's really, really hard to systemise, but it's one thing which I really, really, I think we need to focus on as a system, and that's the whole system. So that's got to come from the top. That's got to come from the chief execs and boards, the leaders of councils and everything else. The second thing is about empowerment. And I can draw upon just another part of life's learning. I remember there was a horrible case. Two young men who were convicted of murdering this guy, and basically the CCTV showed them basically jumping on the poor person's head, basically. And we're sitting and having, in a meeting before it started, and there's two health visitors who basically says, "Oh, I could have told you that. We've been with that family since those kids, were born, and I could have predicted that would happen." And part of me actually thinks, how do we empower, our frontline staff to work out the kind of system we've got? We're all in these systems, got to do this, got to do this, got to do this. How can we actually empower our staff to actually say, listen, I've got a problem here and get it sorted? I would actually argue that one of the few kind of times I saw that actually happening in Scotland was with Harry's Burns, early years collaborative, where he was actually encouraging, staff to say, if you see something, go and try it, plot it, and if it works, let's kind of try to expand it. So effectively, the point I'm trying to make to stimulate discussion is basically, we've really got to push compassionate care to really get to the people who need our help. One of my family members got a letter saying, here's your appointment. If you don't phone this number, you'll be taken off the list. Imagine getting that if you haven't even got a house and you can't read. We need to get that there. And then the second point I really, really want to make is actually, how do we actually give the authority to our staff to do things out of their normal day-to-day life, have a bit of money to do that, and to make the difference to help people? So I'll stop there, Michael. Sorry if I went over the 5 minutes.
No, Gabe, thanks. And some real kind of helpful thoughts there, and some issues I'm sure we'll come back to, particularly that theme about how do we really empower our staff, our people in our systems to really kind of have the freedom to do what they think is right to support the people that they serve. So, but a whole range of issues in there. Great. Thanks very much, Gabe. We'll come back to many of these issues, I'm sure. So we're going to move on, folks, to our next question. It was going to be Susan. We're still trying to get Susan in, I think. So let me jump to Carey. So Carey, we're keen to hear from you around, from your perspective, what policy changes do you think are needed to reduce health inequalities on a systemic level across our public services? And we envisage you will have a particular focus, given your background, on primary care. Carey, over to you. Thanks.
Thanks, Michael. So this feels like quite a hard and big question. So I think just starting off briefly by saying that, as you'd said at the beginning, I've worked as a GP for 20 years, mostly in areas of high socioeconomic deprivation. And I think it's been very humbling to witness on the front line how poverty largely impacts on people's health outcomes, but not just poverty, but stigma and shame and loss of trust in systems, and how they're often the things that we don't measure or see, but they really impact on people's ability to access healthcare. I think in general, I would say that a lot of policy in Scotland has been focused and certainly describes an aspiration to address health inequalities, but the stated aims of policy haven't always been realised on the front line, in large part because of an implementation gap, because it's not easy to do. And I think that it feels that policy is vulnerable to political cycles, to budgetary cycles. It's overly wedded to cautious tests of change or pilots, which are then not scaled up and made into sustainable changes, even if they evaluate well. And I would say there are a lot of the deep end projects that would fit into this category. And then we then get stuck in this pilotitis loop, which I think can be really damaging, actually. Sometimes it could be damaging, more damaging than not having done it at all, because the people that are delivering the care get used to being able to deliver care in a better way, a more trauma-informed way with more time and more support. And the people receiving the care get used to receiving care in a different way. So when the pilot doesn't continue, I think that can feel very damaging and erodes trust and morale. So I think that all policy needs to be developed not just with health in mind, but with health equity in mind, so that we're thinking more about how do we ensure that healthcare is at its best, where it is needed the most to address health inequalities. Otherwise, we won't get any momentum around addressing the inverse care law, where we know that access to healthcare is often most problematic for those that need it most. And we also need it to be coherent, joined up across different sectors, clear national leadership and accountability, and committed to the longer term. So none of these things are easy, but it also needs to be implemented following robust equality impact assessments, but then crucially to be evaluated and monitored for impact after it's been rolled out, so that we can see whether what we thought might make a difference is genuinely making a difference, and we can also monitor for any unintended consequences and change the course if it's not doing what we hoped it would do. And I think another key policy challenge for me is thinking about how do we shift the balance of healthcare. We recognise that healthcare in and of itself drives 20% of health inequality. So it's not the biggest driver of health inequalities. They sit with the social determinants of health. But the way that people are able to access or not access high quality healthcare can mean that it either worsens or improves health inequality. So we have a really key role to play in ensuring that healthcare is at its best when it's needed the most. And a big part of that is thinking about where healthcare sits, whether it's largely based in hospitals or whether it's largely based out in the communities, where I would say that there is so much more potential to address health inequalities. So we see within numerous policies within Scotland, strategy documents, vision documents, there's often a description of the desire to move care closer to home, out of hospitals, of the importance of person-centred shared decision making, emphasis on proactive and preventative care, and more sustainable healthcare. That to me describes very much what we're much more able to do in primary and community-based healthcare, and yet we know that that is largely not where the resources is funneled to. And I know that there are lots of complex reasons around that, but we also know that the global evidence tells us that population health outcomes and health equity are much more likely in countries that have flourishing primary care systems, and in particular in general practice, where about 80 to 90% of consultations begin and end. So if at this point in the healthcare journey, we can ensure good access, we can ensure adequate time to build relationships, we can make good shared decisions and engage in all this proactive and preventative care, then we start to see the benefits. But to achieve this, we need to see adequate support for primary care, and this is where it gets hard because budgets are finite. So again, in one part of the system may feel like a loss in another in the short term, but in the longer term, I would suggest that the outcomes will definitely improve. If we see primary care as underfunded, fragmented, overworked with exodus of its workforce, then we just can't achieve those things and we start to see health inequalities worsen. So I think it's really important to think about how we meaningfully switch that balance and resource and enable the work that we describe to be done more out in communities, so that we can start to address the inverse care law, so that we can start to apply the principles of proportionate universalism in terms of how we distribute resource to flatten the gradient of need. And these shifts need to be informed by high quality and equity informed data and accountability frameworks, so that we can know if we're getting it right. So I guess for me, I'm really interested in how general practice in particular can play this really vital role in addressing health inequalities. And there are three main things, if I may, just really quickly. One is how we build our teams and train our teams. So it's about getting teams on the ground who are trauma informed, equity informed, supported with the emotional labour of the jobs that they do to be able to do them well and compassionately, as Gabe was saying, but critically also how we build teams that are designed to promote social inclusion. So moving away from traditional models that are the doctor, the nurse and the receptionist to one that feels much more modern, inclusive and accessible, that has community link workers, welfare advisors, care navigators working on the front line and linking with communities. The second is how we design and deliver our services. So this is really, really important. Are our services accessible? Are they inclusive? Are they sticky? Do we hold people in rather than seek to discharge people when they're not engaging? A terrible word, but that's one that we often hear. Are they culturally competent? Are they trauma informed? Are they co-designed with our community? So the way that we design and deliver our services is also a key role in, I think, how general practice can do a lot of this work. And then the third is how can we meaningfully use our influence and our advocacy potential to raise our voices on behalf of the communities that we serve, who often have no voice. And there are lots and lots of practical examples of how we can do this well, which I'm really interested in exploring and sharing. So I think it feels like we are uniquely placed to do this, if enabled to do so, because of the long-term relationships that we have with people, the contextual care, the population coverage, and the inclusivity of care, because we don't need referrals into general practice and we don't discharge. So I'm really interested in the key role of general practice and more widely the role of healthcare in addressing health inequalities, that estimated 20% of the driver. Thank you.
Carey, fantastic. Thanks very much indeed. And I was remiss, colleagues. I should have given our other panel members an opportunity to kind of respond to what they heard from first Gabe and now Carey. So let's do that now. We're still trying to get Susan on the panel, but we haven't managed yet. Susan, again, my profuse apologies. But Gabe or Donna or Carey, in terms of what you heard from Gabe, is there anything stimulated by what you've heard from your panel colleagues that you would like to kind of add, contribute at this stage before I bring Donna in to answer her question? Carey?
I'm genuinely really interested in how we ensure compassionate workforces, because I think it's such a key part of what we need to be able to deliver trauma-informed, equity-informed care and address health inequalities. Some of that is about accessing training. Some of it is about understanding how does stigma impact on the way that people feel able to access and accept care. How do people who have experienced a history of psychological trauma make healthy, caring relationships? And we know that a lot of this is very complicated to understand, and it's not well covered in any of the training curricula for health or social care, both at an undergraduate or a postgraduate level. So I think a lot of it is about raising awareness and having access to high quality training. But I guess the thing for me as well is that we don't often then speak about how we create the conditions to be able to hold a lot of the emotional labour of working in a way that is trauma informed, because it's hard to do well. And I think that often what can happen without the kind of safety nets in place, the emotional safety nets in place, is that practitioners can become quite jaded, they can become quite burnt out, they can become quite unempathic, because it's all very well doing the training, but what we also need is to have workforces and workplaces that allow enough time to unpick when things feel really difficult, or when things go wrong, or when people feel criticised or angry, or they get very distressed at what they're seeing in their day-to-day work. So I think I'm really interested in how do we create these spaces to allow people to come together and kind of hold some of that and understand it, and maybe the options for reflective practice, which is something that I had the massive fortune to do for 5 years when I worked in homelessness, but it's not available to most people. So I'm interested in that, because I think it's a key enabler that we don't often talk about.
Great, Carey, really powerful. And I mean, I've heard you kind of say that before, but thinking about it both from the frame of the person we're kind of serving and their kind of ability to trust the people who and the services that have been delivered, but ensuring that we support our people delivering those services, recognising that the kind of support that they need. Yeah, really kind of powerful. Gabe, I see you've got your hand up. Do you want to come in?
Yeah, just in saying what, following up what Carey was saying, basically, this needs to come from the top within organisations. We saw it with the early years collaborative and with chief execs, over the SCDC. Basically, it needs to come through, so it's just continually reinforced as this is the right things to do, basically, and encouraged and praised. And that's the start of it. The bigger things that were raised there, basically, if it ever became dictator, I would actually say, listen, we're going to actually have an independent commission to look at how do we actually support the whole of the public service going forward and over the course of the next decade or so, and effectively actually have almost like a 12-year plan. Because it's like if you're in the factory of having to get through, provide care, you're in a very, very lonely place. We've got to actually refocus how we deliver all our services. I'll stop there.
Great, Gabe. Thanks very much indeed. Some really kind of powerful points and some real kind of common threads running through what you've said, Gabe, and what kind of Carey's said. So yeah, we'll come back to these issues, I'm sure, in the discussion. There's a bit of a theme there around kind of stickiness of our services. It's a pretty ugly word, and I think you said that, Carey, but how are our services compassionate to understand the circumstances of the people that they serve, and aren't kind of, as you said, Gabe, demanding compliance before services can be delivered. So that's maybe one theme that we need to think about. How do we support staff to do that? I'll move on if that's okay, colleagues. We are still, Susan, trying to get you in, but let me move on to Donna Hall, and Donna, invite you to answer your question, and then again we'll have a bit of a discussion before we go into the Q&A session, where we've already got questions coming in, which is great. Thanks, folks. So Donna, as you know, the question we posed to you was, we know that interventions aimed at tackling health inequalities need to be sustainable if they are to lead to long-term improvements to overall population health. What lessons can we learn from successful interventions today? And we know you bring huge experience from south of the border from that, and we'd be really keen to hear that. Donna, over to you. Thanks.
That's great. Thanks very much, Michael. And it's brilliant to listen to Carey and Gabe. And I think a lot of what I'm going to say will hopefully resonate with their points, because I totally agree 100% with their analysis. So I'm a resident of the Scottish Highlands. I've been for the last few years. So although a lot of my experience is from Wigan, Chorley, and the integrated care systems that I support, I live in Scotland, and really I think there's some amazing work going on in Scotland too. So a little bit about, to answer your question, I'll focus on a bit of a context. I think we underestimate just how broken public services are across the UK at the moment, and the complete disarray that we find ourselves in at the moment in terms of our obsession with assessment and referral, that kind of impersonal, inhuman approach. We do that all the time. We're segmented, we're silo driven, the costs are going through the roof, and we've lost something. We've lost that humanity. The reason people become public servants is to help people, not to continually assess people and refer them. And what we started to do back in 2011 in Wigan was we did some work with children whose families were really struggling and who were on the edge of going into children's social care, the edge of being taken into care. And we worked out what we were doing collectively as a system to support them. We found we were spending between us, so that's the police, criminal justice, social care, health, housing, mental health, drug and alcohol services, everyone involved in the lives, excuse me, of those families. And it was every year between us, between £250,000 and £500,000 per year per family. And at the end of the year, the most heartbreaking fact was we had social workers in tears when we worked this out. They were in a worse position, usually, or the same position as they were at the beginning of the year. And we're spending all this money collectively, 80% of our time on assessment, 80% of our time on measuring people against eligibility criteria. Very often telling people, I'm sorry, you're not bad enough to access this menu of services that I've commissioned for you. Go away, get worse. And then when you are worse, come back and I'll let you access my very tightly defined menu of things that I think you need. So completely shifting the role of public service is what we tried to do in Wigan, completely redefining the role of the state and the citizen into a partnership arrangement. That's what the deal was all about. It was a new social contract between citizen and state. We kept it really simple and really high level. Plan on a page. Every strategy was on one page. It was written with a reading age, average reading age of 8 years old, which is the average reading age in many parts of the UK. And we kept it really simple. We froze council tax for 8 years to kind of help support people through the worst years of austerity. And at the same time, we said, tell us when we get it wrong. So this thing about compassion and humility, we're not right all the time. You know, as somebody with lived experience, somebody who uses services, somebody who suffers from a condition, somebody who's homeless or with learning disabilities, you know the reality of your life. We don't. We're just here to try and help often, and commissioning very often in ivory towers. So let's really turn the whole nature of public services around and start to get back to being servants of the public rather than commissioners of services and gatekeepers of eligibility criteria. I remember at one point I was asked to run the clinical commissioning group as well as the council. And I was shocked really with some of the practice in there. So eating disorder services, for example, we told people if you didn't have a certain BMI, if your BMI was too high, you had to go away and get worse and then come back and then we'd help you. You know, what kind of place have we become where that is our job, to design services that keep people out rather than supporting people and helping people to live their best lives? So what we did was we basically used an anthropologist to help us retrain everyone that we work with in ethnographic techniques and how to really listen to people. And we did this thing called the Wigan experience, which was about values and behaviours of the workforce. And it was very much around getting people to really reconnect with the person and the core purpose of being a public servant. And we gave people the permission to innovate in integrated frontline teams. We said, go and do what you think is the best thing to support that family or that person or that neighbourhood or that community. I worked to support Andy Burnham in Greater Manchester, and we had this thing called names, not numbers, because we're obsessed with numbers, aren't we, in public services. So let's get to know the person, where they live, which house they live in. Let's do risk stratification. Let's identify who needs the support before they need it, whether it's school readiness, an unplanned hospital admission, a fall at home, homelessness, debt, whatever it is. We know usually what situation that person's in before it happens, and yet we just wait for crisis, for people to tip into crisis. So we completely changed the way we work with people. We invested over a 10-year period, 12 million in community and voluntary sector projects that weren't designed by us, but they were designed by people with lived experience, whether it was mental health, substance abuse, whether it was loneliness and isolation, obesity. And they designed, with local community organisations, a different model. We funded 500 brand new projects to support people living in communities who needed that support. And in the end of that 10-year period, we managed to add an additional 7 years of healthy life expectancy in the most deprived wards in Wigan. And that was at a time when everything was going the other way. So the King's Fund have written a really good evaluation of it, lessons from the Wigan deal, a citizen approach to population health. And it was very much around the people, us serving the people, an equal partnership rather than public servant knows best and will tell you what you need. Integrated neighbourhood teams, frontline people working together, forget your lanyard, forget who you work for, stop. And very often the needs that people have don't fall neatly into a service. Very often the needs are social, environmental, community-focused needs. So let's help support people in the community to help people live their best lives. Let's focus on social care. You know, councils across the UK at the moment are saying there are only 2 or 3 children coming into children's social care away from bankruptcy. Why is that happening? Why are we sending people, children and young people, with all this stuff in a black bin bag around the country, around the UK, saying basically, you know, this privatised service that we've developed, why are we doing this? Hugely expensive, really terrible outcomes for the child and for the family. Let's think of a different way. And Really, that's what I think needs to happen. So sorry that I've gone on a bit longer than 5 minutes, but I'm going to show some slides at the end about some great work going on in Gateshead. I don't know if you've seen it, called the Liberated Method. It's exactly what Carey and Gabe mentioned at the beginning. It's freeing up people to do the right thing and support people. And it's system-wide. It's not just one organisation, everyone's doing it. And they're going to show you the story of a guy called John at the end under key messages. And I think hopefully that'll bring it home to you. Cheers.
Brilliant, Donna. Thanks very much indeed. It's really impressive. And I look forward to hearing about the Gateshead experience. I've read about Wigan, I've read the King's Fund report. It's hugely powerful, and I think there's real lessons for us in Scotland to learn from the approach you took there. And just that stat about increasing healthy life expectancy in your most deprived communities by kind of 7 years is hugely kind of impressive. Thank you very much, Donna. Look forward to continuing to hear from you. Folks, we've had to give up, and Susan, I'm really sorry that we've not been able to get you in as a member of the panel. My profuse apologies. But I was keen, and it builds on what Donna says. So this is the question that we had that Susan was primed to answer, but is unable to because of the technology. But it builds on, I think, what you said, Donna. So I wonder if, Donna, you or Gabe or Carey, or maybe all of you have a view around the question that we had envisaged that Susan would answer at this stage, which is around how have grassroots organisations played their part in improving the health of communities at local level. And I wonder if we should take that further and ask about your views about what more we could do to support grassroots organisations. And I think the experience that you've just described of that investment in those 500 projects is maybe an example of that. But keen to hear from the panel around those issues. Gabe, you've got your hand up, so I'll bring you in first. Thanks. Gabe, you're on mute. Sorry.
That's another 10 bob in the swear box, but never mind. See a view from there. But Michael, I'll kick off and what I was just saying. My apologies to Susan, because I wouldn't do any justice to what she would have done basically from there. I'm thinking back in my time in the mid-80s, where basically the Strathclyde region, which effectively used to be like half of Scotland, basically had, community development workers. Effectively they're gone, from there. There might be a few still surviving. Effectively, like the voluntary sector has become the new way of delivery, basically. And I've got examples from my time in Lanarkshire. There's 3 in particular where basically they've actually stood the test of time. They've survived for almost 2 decades. And how they've been successful is because they've actually had someone at the top of that, the lead, who's actually is just so sharp, they kind of they understand the politics, they know how to establish relationships and to keep things going. But I actually took the time to actually, reconnect with one. And she said, basically saying, listen, I'm spending most of my time chasing funding. I'm not actually doing what I'm actually getting paid to do. I'm actually trying to keep this alive, basically. So I think one of the kind of key challenges for us going forward is actually, how do we recognise the voluntary sector, the third sector, whatever you want to call it, are actually just a part of basically a public service? And how do we get away from the point of view of actually saying like every 2 or 3 years they're up to actually to get their funding renegotiated or whatever, basically. So I think it's a real challenge for us as a system to actually say we actually value and will make things happen. And I suppose the one kind of analogy I look at, see if you're trying to get a new clinical service, and the time in Lanarkshire, a new clinical service was trying to get funded. They get put through the ringer, to actually to make the case. But once the case was made and the funding was approved, that's Siri talking to me. Once that funding was approved, it was allowed to then go and deliver. It wasn't called back in 2 or 3 years' time to actually to say, what have you done, basically. So we've got to actually start applying some of these principles to how we actually support, our colleagues in the third sector. I'll stop there and hand over to Donna.
Great. Donna or Carey, do you want to come in on that point? You make a really good point, Gabe, around the amount of effort that third sector colleagues spend chasing funding. For a number of years actually was a trustee of a small kind of charity in Edinburgh, north of Edinburgh, called The Junction, who support young, vulnerable kind of young people around sexual health services, but more kind of broadly. And I got a real sense there of how much time the director in particular, but her team spent chasing resources to continue to fund, where a real sense of frustration that meant her and her team weren't able to focus on supporting doing the work they were really determined to do. So some real lessons for us there. There's issues around multi-year funding, I know, there as well, which is a challenge for everybody right across the public and third sector. So no, really helpful. Donna, Carey, any kind of perspectives from you on that point around kind of grassroots third sector community organisations?
Go on, Carey, you go.
Yeah, go on, Carey.
I guess really just to say that particularly during the pandemic, the really crucial role of grassroots organisations really came to the fore. And I remember well working in practice at the time. It was right at the start of the pandemic. We were very concerned about the medically vulnerable, rightly so, but we'd sort of maybe slightly forgotten about the socially vulnerable a little bit right at the beginning when we were doing a lot of the work around shielding and, you know, prioritisation of care. So I remember being through in the reception area of the practice, speaking with a community link worker in our care navigator team, and they were saying, we're really worried about the people that we're not seeing that we normally see that just come in because they're struggling. So this is, you know, the big part of, I guess, community-based healthcare, that is not about medicine, it's about more than medicine. And they were so crucial to kind of raising awareness around this missing group of people that we should be worried about. So we sort of made a list of those people and we contacted them just to say, are you okay? Do you know that the practice is open? Do you know how to keep yourself safe during COVID? How are things at home? Have you got enough food? Have you got enough heating? Are you feeling safe at home? Do you know how to keep yourself well? And 8 out of 10 of those calls resulted in a referral, either into the practice to see someone or to link into one of these grassroots community organisations. And the role of the community link workers were absolutely key to this for us, because it's really hard to keep up to speed with everything that is going on in a local community, particularly when funding is unsustained, is short term, and we don't always know if things are still available or not to people. So community link workers for us are this really, they're the conduit to us for the kind of social support that's available out in communities. And I guess my appeal would be sustainable funding for third sector organisations, but also sustainable funding for community link workers, particularly in areas of deprivation. There's been huge concerns around this in Scotland, as you'll probably know. We've got more than 250 community link workers in Scotland, most of whom are located in areas of highest deprivation, but their funding does not feel secure. And what happens then is that even if there are last minute interventions to put funding in, it creates massive insecurity and anxiety within the workforce, and really good people leave. And these are people that have built up relationships with communities and practices over many, many years. We can't afford to lose these people. They are, I think, a real golden nugget in how we address health inequalities around linking people with organisations that support social isolation, domestic security, exercise, gardening, food security, domestic security, all of this stuff. So yeah, that would be my thought. Thank you.
Thanks, Carey. You make a very powerful case, and particularly around community link workers, and it's one that I've seen the evidence of the benefits the community link workers bring, and I think it's an important lesson for all of us, despite the financial challenges we face right across our public services. Donna, anything you want to add, building on what you've already said on this point?
Yeah, I mean, I think it's because of the financial challenges we face that we need community link workers. You know, you think if we're not supporting people through community link workers, they're coming into the really expensive acute end, and that's much more. It's like 3-4 times as expensive. And that's what they've done in Gateshead. They've brought more generalist community link workers into the system to really work differently with communities, and it's essential that we do that. And I think very often, you know, we'll protect the acute, won't we, at all costs, or protect the acute. When there's an overspend, just give it more money. And, you know, so Greater Manchester, where I'm from, 180 million overspend in NHS Greater Manchester, and they've just been given it. I'm sorry, it's wrong. You know, that is wrong. You know, we've got to think differently about the way that we deliver our services. I also think we've got to start to think differently about the relationship between the community and voluntary sector and public services. It's often one of suspicion. We don't really believe in them. We don't really think they're going to do a good job. And we micromanage them to within an inch of their lives for, you know, a £10,000 grant. We spend more than they actually give in the grant on managing them and micromanaging them. And that relationship is not one of trust. So we completely transformed that relationship through the Community Investment Fund in Wigan. We believed in people. Of the 500 projects, only 2 ran away with the money and didn't deliver. So that's not bad, really. And we got much more because that relationship was one of trust than we would have done if it was one of micromanagement. I think the whole way we buy and commission and procure needs to be changed as well. I chair a social enterprise for people with learning disabilities and autism. And very often we get invited to bid for things. But it's very much a kind of, you cannot talk about this bid. You will just have to put in a tender, no conversation about it. And there's literally no conversation with anybody who actually has learning disabilities or autism as part of that procurement process. None whatsoever. So they're basically procuring in the blind, spending money, wasting money on things that very often are not needed and not wanted. So we've just got to completely change the relationship of public services to citizens. That's at the heart of what I was trying to say. And I'm so sorry Susan's not here because she's brilliant and she would have said it much better than we have.
Yeah, I'm really sorry as well, Donna, but thanks for your contribution. We'll need to do this again, folks, and get the technology right so we can get Susan and hear from her. Great, really important. So we have theme of trust coming out for me from the discussion so far. So trust in our kind of our staff and those supporting, serving the colleagues and people in our communities, but also trust between public services and kind of third sector organisations as well. And what I'm hearing from the panel is a strong sense of actually that trust is broken down in both those respects, and actually part of the solution must be to rebuild that trust. So that's maybe something we can come back to in terms of the questions. Folks, we're going to move on to the questions now. We've had a whole range of questions submitted, and I'm really kind of grateful. And I've got the kind of order here, and I can see that they helpfully build on the discussion today. So what I'm going to do is just articulate the question and then ask our panel for their views in whichever order they choose in terms of the question. And we'll run this now till about just at 11:20, maybe just after that, because we want to give the panel members a chance to have a final kind of takeaway message. And you've heard a bit of a preview from Donna already about what she might say about Gateshead, which sounds really interesting. So I want to protect time for that. So that's where we're going to, colleagues. So let me start with the first question, and it really builds on the discussion we've just had about the important role of the third sector and grassroots and community organisations. So the question is, the third sector is deeply concerned about the impact of the Scottish budget as it filters down to community groups, volunteer organisations at the heart of tackling poverty, inequality and sadly destitution. We fear the loss of. How can we get national and local decision makers to understand this and the damage likely to emerge? So who would like to kick off on that topic? Donna.
I think it should be the other way around. I don't think it should be down to the community and voluntary sector to make the case. I think it should be down to Scottish Government and decision makers to really look at the what will happen if we continue as we are, if we continue to cut services that are community and voluntary in focus. It's a huge investment in prevention to fund the community and voluntary sector, and it pays back tenfold, in my opinion, probably even more than that. And again, you'll see from the end of some of the stuff they're doing in Gateshead and what we did in Wigan and what happens in parts of Scotland too, is people who invest in the community and voluntary and third sector, it pays back, you know, financially and in terms of outcomes. So, you know, why would you not do it? People might do it because, a bit like the UK government, they cut local government because it's not them and it's easy to do it. Sometimes I think we all do that, don't we? We cut people who are not us. and pass the burden on. But it's absolutely a crazy thing to do, to cut the community and voluntary sector. Just does not make sense at all.
Sorry, I had my mute off. Brilliant, Donna. Thank you. Gabe, you've got your hand up.
Yeah, a couple of points in this one, like Michael. We've got a manifesto commitment from the government, Scottish government, for the world-class public health system. That was kind of kicking in around the time of, like the pandemic, basically, from there. The reality is, like, how do we have a fully funded, like voluntary sector to be part of that world-class public health system? I know it's really challenging. We're through austerity and everything else, basically, but we've got to keep making that case. It might not happen just now. I remember a story I was doing the MPH. It was a retired DPH, was talking about the history of the chief medical officer, I think it was called, that in Glasgow, basically. And effectively, everyone who actually called for the slums to be cleared get sacked. But what actually happened, the person that came after them actually cleared the slums, from there. So the reality is, what we've got to do is we've got to continue to make that case. And at one time, we'll find the right conditions to make that actually happen. But I really do believe we really need to actually reconfigure how we deliver all our services. Stop there.
Great, thanks, Gabe. And can I just take the liberty as chair of, I'll bring you in a sec, Carey, of saying from a Public Health Scotland perspective, we think part of our role as the national public health body for Scotland is being that advocate for the power of investment in prevention, in community and grassroots organisations. And let me just reassure you that that's something we are doing. We do it kind of publicly in terms of some of our publications. We published really important, we think, work on the value importance of prevention over the last year or so in Public Health Scotland. But in terms of our discussions with government and with opposition parties across the Parliament, we are seeking to make the case about the importance of that investment in prevention. And Paul Johnson, the Chief Executive, and I were in discussions yesterday afternoon at the Scottish Parliament with, I won't tell you who, but with opposition MSPs making precisely that case. And to be honest, real kind of sympathy there amongst all the parties around them. But we need to see politicians nationally and locally deliver on that. So I want to be clear, we recognise in Public Health Scotland our role in being that advocate for the understanding of the value of that work. But Carey, I'll bring you in, and then Gabe, you get another shot, and then we'll move on to the next question.
Thank you. I think this is a really important question, because I think this kind of gets to the nub of what can we do and how can we do it, which I think is often where we often end up landing at the end of these discussions, and it can feel a bit overwhelming and a bit hopeless. So I think it feels to me like there are two sides to how we tackle this. One is from the ground, and I guess maybe one is, I don't think from the sky is the right part of the metaphor, but one from the ground, I think it's important, and I would agree with Donna, it's not really the responsibility of the people that are delivering the service to be able to make the case for why their service is important. But I do think that there is real power in community organisations, health organisations, voluntary sector organisations, all coming together with a collective voice to say, this is what is happening by removal of these services. So I'm particularly, interested through the work of the Deep End and the work that we've done that has been collective lobbying, for example, around the removal of community link workers, or the threatened removal of welfare advisors, which are another really key role of how we ensure social support in practice, having welfare advisors in practice. So I think working together to make the case, both by clever use of data collection, but also narrative, which I think is often missing from discourse within government. This is how it feels on the ground. Stories from the front line, anonymised, of course, but this is how it impacts on real people's lives, on real families, and then using our collective voice, whether it's through parliamentary petitions, whether it's through inviting MSPs to visit practices or visit places of work out in the community, whether it's through effective lobbying and advocacy work. So there's a lot of stuff about this on the Deep End website. And then I think from the other side of the coin, it's ensuring that we have meaningful accountability frameworks for what we say we're going to do within government, translating into what we actually do, and then understanding whether or not policy is actually making things worse or making things better. So that meaningful data collection that then drives improvement or change of direction as well, but also making use of the existing legislation and duties like the Fairer Scotland duty and various other pieces of legislation that very specifically talk about the role of public services and lots of other parts of the system in addressing health inequalities. I'm not sure that we make the best use of that or that we use it to its full power to challenge the decisions that are being made. So I guess it's from both sides.
Great, thanks, Carey. Gabe?
Michael, just very, very quickly, see, Donna talked about a sum of 12 million. See what we're talking here in the third sector, see, to use one of my favourite phrases, it's washers. In the scheme of things, it's absolutely washers in terms of what we're actually talking about here. And I'm sitting on a cross-party commission, looking at 70-30 prevention of abuse to children, basically. We worked out something like 4 to 6 billion that we could actually save the Scottish economy if we actually kind of got this sorted, basically. So we've got to be pushing on this, the actually value for money for actually investing in this. And the return on the money is phenomenal. So we want to call it social return on investment. We've got to make that case. Thank you.
Brilliant. You can tell the man from Lanarkshire using washer. I would call it pennies, but you're absolutely right. You make a really strong point. I just want to react very quickly to one of the things you said, Carey, because I think that point around how our policies framed, how our duties on public bodies, do they support us in tackling kind of improving health equity? One of the things we're doing in Public Health Scotland is working both with Scottish Government and with Sarah Boyack, MSP, on there are kind of competing bills around well-being and sustainable development. And one of the ideas in both the bills is that we might have a future generations commissioner equivalent to the one they have in Wales, in Scotland. And that's really, for me, I suppose, around systematising that longer term approach, about systematising that focus on equity and tackling inequalities. And one of the things we are doing in Public Health Scotland is advocating for that approach kind of publicly and across the Parliament, but also practically trying to help both Sarah Boyack and her team and the government team who are thinking about those bills. So more on that, because I think there is something around how do we make sure public sector and its duties support putting health and well-being at the centre of everything we do. So more on that. Let me move on to the next question. I'm going to kind of change it up in terms of, I'm not sure if the order's been kind of published, but I was keen to get into some of the questions around kind of the social determinants of health that we maybe haven't spent a lot of time. And there was a question which I thought is quite difficult actually, but I wondered if might help get us into that space. So with apologies to the panel, I'm going to go to that question next, which is question 7 on my list. So the question is, what are the panel's views on the extent to which addressing health inequalities in Scotland requires a focus on economic factors and on economic policy systems change at a wider society level versus, or perhaps as well as, a focus on supporting those who are most disadvantaged? I think that gets into that social determinants of health question. I'd be really keen to hear if the panel had views on that question. Who would like to kick us off?
Michael, can you give us the question again, please? Just so
Yeah, so what are the panel's views on the extent to which addressing health inequalities requires a focus on economic factors and economic policy systems versus a focus on supporting those who are most disadvantaged? I'm not sure it is a versus. My own perspective is we need to do both, but I'd be keen to hear the panel's perspective on that question. Donna, I'll bring you in and then Carey. Thanks.
Yeah, thanks, Michael. I think it's a really good question because I think often the two are done separately. You know, initiatives to address economic development are completely separate to initiatives to address health and wellness. But I think, as Carey said in her introduction, the two are intrinsically linked. with poverty as a real defining factor, and looking at the Marmot recommendations, you know, all of the things that Michael Marmot says that we need to do have got an economic link to them. There's a really good piece of research that's just come out. It's all, oh no, there is they did use a part of Edinburgh as part of the research. IPPR, Institute of Public Policy Research, came out. It was launched on Monday. I spoke at the launch event with Andy Burnham and Norman Lamb, and it was basically recommending the creation of health and prosperity improvement zones across the UK, where the two pieces of policy come together, and we work differently to support people. One of the best things we ever did in Greater Manchester was we did this thing called Working Well that Andy introduced, where basically we used primary care, GPs, as the main kind of trusted. I think GPs and schools are the most trusted public servants in a neighbourhood. So well done, Carey and Gabe. You are most trusted than anybody else. Councils are not trusted, really. DWP are not trusted. And what we did was we looked at people who were long-term unemployed and asked people to go for an appointment to the GP, and let's do some more intensive work around the reasons behind, you know, what illnesses you have, how, whether it's mental health, and it usually was, how we can support you back into employment. The success rate of getting people back into work through that, you know, linking economic development, linking DWP and linking primary care was amazing. So more initiatives like that that bring the two things together, and not just creating job opportunities that we expect will trickle down to the poorest parts of Scotland and the UK, because it doesn't trickle down. We all know that.
Thanks, Donna. Really powerful. Carey.
So I would agree with everything that Donna has said, and what you said, Michael, at the beginning, which is, I don't think it's an either or. Of course, we need to address the social determinants of health. It's the biggest driver of health inequalities. And when you look at poor health outcomes, they very closely mirror poverty. So we can't not address poverty, because poverty impacts on people's choices, the ability to have their voice heard, their ability to navigate complex systems and just live well and live healthy, fulfilling lives. So we need to focus on that as a bigger picture thing, but we also need to think closely about how we ensure that our healthcare systems are doing their part, their estimated 20% impact on health inequalities. And it goes back to a lot of the things I was saying at the beginning in terms of how do we make sure that our healthcare services are at their best where they're needed the most. Because if they're not, then they will actually worsen health inequalities. So if we have a system that doesn't have its resources matched according to the needs of its local populations, then some people will be able to better make use of services than others, and we see health inequalities worsen. So we need caution around lots of different things in modern healthcare, like remotely delivered healthcare, like healthcare that requires people to travel a great distance or read lots of material at a reading age that makes it difficult if health literacy and functional literacy levels are low. Appointment systems that come out to insecure postal addresses, and it's 2 strikes and you're out, and then you're off the waiting list and back to square one. We have systems that are really not designed for the people that need them most. They're often designed by healthy people for use by healthy people, and they're not designed for the people that need them the most. So in terms of supporting those who are most disadvantaged, I think there are lots of discussions ongoing at the moment about whether we target certain cohorts of people with more support, which has some advantages, or whether we apply a proportionate universalism approach, which is where we maintain the founding principles of the NHS so that there is universal coverage, but that resource is then matched to the level of need. So it's about flattening the gradient. And in many ways, I think that feels like a fairer way that is harder to argue against and is less stigmatizing than saying you are getting this because you are homeless or because you live in a certain type of community. So I think it's both, and I think we need to be careful about how we match resource according to need, and using the language of fairness, which is difficult to argue against.
Great, thanks, Carey. Gabe, your perspective would be really helpful.
Michael, there was work done in New Zealand about 12, 14 years ago, and I don't understand the New Zealand system, but it's a kind of crazy kind of like private, like mix between public and private sector, basically. And what they did is they got actuaries to come in to actually look to see where are we going with this. And they looked at one area, it was like adverse childhood experiences. And effectively, the expectations of spend on a person up to the age of 35, if you didn't have any, it was like something like 35 Kiwi dollars. See, if you had 4 adverse childhood experiences, the expend was something like 235,000, like Kiwi dollars. And what the actuaries, the money men and money women, basically says, you cannot afford to go on with this. You need to actually start to do things to actually try to prevent these things. So the reality is, I think Donna actually said that we can't think of these in isolation. These got to be actually quite intertwined, and we've got to actually look at that in that way. And maybe that's how we build the arguments going forward.
Great. Thanks very much, Gabe. So a bit of a consensus there amongst the panel that one of the things when we think about health inequalities is tackling the social determinants of health is really important. And that's certainly something we are pushing hard in Public Health Scotland and that work and prevention I've talked about in our kind of general approach, but also thinking about how we support the people who in our most deprived communities or most of need of our help. And I think it's not an either or, we need to do kind of both, but that focus on primary prevention being a really strong point that made. And that IPPR report that you described, Donna, sounds kind of really interesting. It almost feels, folks, if we need to do a bit of a bibliography kind of after today that we can share with participants about some of particularly the kind of evidence that you've described, kind of, Donna. So we think about how we best package that and make that easily available to folk, although people can clearly do kind of Google and access it for themselves. So thanks, really helpful discussion. Let me think of the next question. I've got a question here that I liked, and I'm not going to ask the person, and I don't know who asked this, but it's a personal question, and the person asking, who's anonymous, discloses about their background, but I think it's a good one. So the question is, as someone who's old enough, so this is not me, although I am old enough, to have worked in the old community health projects, in fact, in the original Ferguslie community health project back in the days of Healthy Cities, do we think that's a model that we should revisit and seriously consider? Donna, I'm not sure how aware you are of those kind of models, but I'm pretty sure Carey and Gabe will be aware of them. And do we think that that's an approach that we should revisit? Any views? Gabe, I might come to you first, if that's all right. I imagine you will know about those approaches.
Yeah, kind of, this is going back way back basically from there. Michael, I think kind of like these type of approaches, the approaches we need to take, and I suppose one of the points I was hoping to make in this kind of like seminar basically was like we're very good in Scotland at doing what I would call individual dosages. So we do one bit of work, we evaluate it, and we show it works really well and all that good stuff from there. But what we don't do is we don't do that industrial dosage, across the whole of the country. So, it could be Elderslie, it could be Glasgow, Healthy Cities, it could be the Wigan stuff that Donna's, like talked about from there. What we need to do is do this actually across, the whole country. We've only got a really small population, basically. Why can't we actually drive that whole approach across the whole of the country and then make that difference? I think the real challenge is basically what we do, short-term funding, we find a reason to ration it, and basically we do that basically, and then we cut it off. And then I think, like, Carey talked about it at the very start of this, we lose communities because we've done all this work, we've raised all these expectations, then we say, oh, sorry, folks, we're off. And it really, really gets the community basically from there. So I think like we've got to learn from the past. Done these things, we're sure they've got potential or they're working basically, and then we just walk away from them. We've got to stop that cycle. I'll stop there.
Great, and goes back to Carey's point earlier about kind of pilotitis and how that breeds mistrust and lack of progress. Donna, any kind of views from if you get a sense of what we're talking about here, about kind of from your experience.
Yeah, no, I totally agree. I think the two things that the King's Fund said about the work in Wigan was, the first thing was, it was clarity of purpose. What were we there to do as a partnership? What was the job of public servants, and how do we work with citizens? It was dead simple, dead clear, and consistently, as Gabe said, driven through everything. Every single person went on this Be Wigan experience. Everyone who's a public servant working in the place went on this values-based training around courage and supporting people differently and innovating. And then the second thing the King's Fund said was, it was constancy of purpose. So instead of keep chopping and changing, as Carey and Gabe have both said, having new initiatives, new plans, new strategies, we stuck with it, and it's still going on now. I retired a few years back, but it's still going on because it's by the people, and it's about the place, not about the individual ego of the leader who's in that job. And I think we tend to find that you get a little pot of money. My background's policy and strategy. I've written hundreds of the blasted things. None of them have worked except this one, because it describes a relationship. It describes a relationship, and it's really clear, and it's just, you stick with it. You don't keep changing and create a new one when you get a new leader. I did some work with Birmingham a couple of years back, and they had, I think, something like 4 chief executives in 4 years, and they had 4 different strategies, and no one knew what they were doing. You ask anybody who works in Birmingham, what is our strategy? They haven't got a clue. So a strategy isn't a strategy if people don't know what difference it makes to the way they work.
Great, thanks, Donna. Carey, any perspectives from you? I mean, particularly given your work in GP practice, largely support in areas of kind of multiple kind of deprivation, about what you've seen that works. Kind of, I suppose, I mean, you've described very powerfully today, and I've heard you otherwise, in terms of what works in terms of your approach to primary care, but what works more generally in terms of the communities that you have been a part of and worked in?
So I don't actually remember healthy cities. So I would be lying if I was trying to give an informed opinion on that, but I would agree with everything that's been said around the principles underpinning it. If something is working well, we need to capture the essence of that and sustain it, rather than keep reinventing the wheel and eroding trust and morale and sense of purpose and all of the stuff that we've talked about. I think when I was listening to Donna talk about the Wigan deal, which I was so pleased to be able to hear from her firsthand, because I've read extensively about the Wigan deal and just think it's amazing. Some of the elements of the essence, I guess, feel not dissimilar to the Govan Ship project in Scotland, where it was a 3-year funded pilot, and it was based in Govan in Glasgow, and it was about genuinely integrating on the front line healthcare and social care and other organisations, including the third and voluntary sector, for the most vulnerable families who tended to present the most frequently across multiple parts of the system. And no surprise, if you bring people together, people all have their knowledge of the families that are vulnerable, but they don't always join up the thinking around it because they have different databases and different systems that they're working within. But if you create the time for people, professionals, to come together to talk about the families they're worried about, to bring together the different data they have, to do some proactive care planning, to think about what might actually work well tailored for this family to try and support them to stay well, and have a more preventative and proactive approach, it makes a difference. So, and it's about the essence of just the things that we know well, which are about, I guess, protecting the relational elements of care, whether it's care within health or care within a community setting or care within social services. We don't, I think we're going back to what we said at the beginning, we're kind of in peril of moving away from that more than we realise, because we become so embroiled in targets and paperwork and counting and doing things online, that we forget how powerful it can be to just come together and have a conversation and hear directly from someone about what it is that really matters to them. And we talk about it a lot, but we don't do it as much as we should. And it's what makes the job feel fulfilling. And it's actually what reduces burnout, I think, for many, when you feel that it's what is working well.
Great, Carey, really helpful. Carey, I'm going to ask you a question. It's a bit cheeky, so please forgive me if but I've heard you talk powerfully about the work you've done in Craigmillar in particular, and I suppose when I think about the approach that Donna talks about, it seems to me that's around in any individual community or kind of neighbourhood, GP like you and your kind of colleagues coming together, but also with the school, the head teacher in that area, with perhaps the police that are working in that community and other public services too. And I suppose my question for you is, does that happen in relation to Craigmillar, for example, or other areas that you've worked in? Is there something that we need to think about in Scotland, whether that's going back to healthy cities or neighbourhood, whatever the kind of label is that allows that? And part of the reason if I'm asking Carey, and I don't know if we've described this to you, but one of the pieces of work we think is quite a kind of a glimmer for us in Public Health Scotland is what we are doing to support secondary schools and giving them bespoke information. It's not generic information, but bespoke information about the health and social care needs of the community that they are operating in, the kids that they are supporting. And I'm just wondering if we're doing that kind of join up enough in your experience, or is that something we need to think a bit more radically about in Scotland? Sorry, Carey, hopefully that makes sense.
No, it absolutely does. And I think that certainly those types of interprofessional relationship building opportunities were something that we talked about a lot in Craigmillar. Did it always happen? No. And it wasn't because we didn't want it to, it's because we literally spent all our time firefighting demand. And that is the inverse care law in action. It's a very busy practice. It's under-resourced for the level of need. And it's very difficult to kind of get your head above the parapet before 8 o'clock at night to then think, oh, it would have been really good to engage with the local school today. So, but I think that when it has happened, and it has happened at points over the years when we've had, we've tried different ways of working. So, for example, we had a primary care mental health team of nurses working in our practice. At one point we had 3, and we were doing some really fantastic interface working with the local high school, which really struggles with its attainment, and also really struggles with the mental health of its pupils. And so we were seeing a lot of the same people, and our lead mental health nurse, Kat, who was absolutely phenomenal, would go over to the school on a reasonably regular basis, just check in with the teachers and do some support work with them, almost like reflective practice with them, but also make sure that we were using common language and common advice around well-being and mental health for students and young people when they were presenting either to us or to the school, but also along the way building relationships with the school, which felt really powerful. I think that the third sector, our link is community link workers with the third sector. We would love to have more time. We've run events in the practice where we've invited third sector in to come and have stalls in the waiting room and invite patients in and just have discussions about community assets and building health. But we would love to be able to do it more, as would most practices, because it's the sort of thing that gives you joy. But I think that there are also some really great examples in other parts of Scotland where there are meaningful lived experience groups that have been established. And this for me is key. And it's really not done well, not because people don't want to do it, because it's hard to do. And you need to put a lot of time and emotional effort into making these groups work really well and feel supported and feel heard. But the Chance to Change group in Drumchapel is a fantastic example of a meaningful community connection group that has really influenced how the practice runs, and is actually also a lived experience group with Scottish Government influencing policy making in primary care, which is great. So I think there are some enabling things that we need to think about how we make that happen. Maybe having health equity champions in general practice, looking at how we manage workload, how we resource that time to free it up, like the governorship model, to have those conversations. And some of the work that's being funded in Glasgow at the moment, which is part of a pilot called the Inclusion Health Action in general practice, which is just giving a little bit extra resource to practice to do things differently. And one of the streams in that is community engagement. So there are lots of there's a reasonable evidence base of what works. It's just making it happen in a more sustainable way. Sorry.
Thanks, Carey. Really helpful, and thanks for responding so eloquently to a question you weren't expecting. And I think I should have made that point around that the community themselves lived experience bottom up rather than top down. There's no good professionals coming together to, even if their relationships are really good, if the community aren't involved. Great. I'm going to ask one more question. I'm going to give you a minute each panel members. It's a really tricky question, so apologies again. And then we'll go into the wind up and give you a chance to give your kind of takeaway message. So it's a bit of I'm changing slightly the question, but the question for each of you is, what concrete actions should Scottish Government, NHS Scotland and PHS, so please feel free to point this at us, take to address health and healthcare inequality? So maybe one or two from each of you, concrete things that you think Government, NHS Scotland and PHS should be doing to improve health equity. Gabe, I'll go to you first.
Yeah, please, in a minute. One, cross-party, get cross-party support. Two, ban short-term funding. And then three, pick the big ones which are going to actually make a difference and do them on a universal scale. And don't allow the word pilot to be used. Stop there.
Great. Under a minute. Brilliant. Donna, do you want to go next?
I think build an evidence base of where investing really pays back well, and that's bound to come back to the link workers and community and voluntary sector, third sector. You know, really look hard at where cost lies. Don't just cut things because they seem easy to cut, because that's going to have a negative impact on demand. It's going to come up elsewhere in a much more expensive bit of the system. And as Gabe and Carey have said throughout, stick with it. Have it as a long-term multi-agency strategy across health boards, across local government, so it's everyone working together for a long time period to do it.
Brilliant. Thanks, Donna. And Carey.
Can I just say what they said?
You can.
So, yeah, what they said, I think national leadership on health inequalities, so that there is kind of clear cross-sector knowledge and accountability of what's happening, because I think often it feels very siloed, would be good. Making sure that we make the best use of the legislation and the statutory duties that are out there, making sure that we do meaningful impact assessments before things are rolled out, but then crucially that we monitor and evaluate them for how they are working on the ground, and thinking really carefully about the decisions we make about healthcare, that 20%, coming back to that. How do we make sure our workforces are in the right place? How do we make sure that they're trained and enabled? How do we make sure they're socially inclusive? How do we prioritise the work that is done? How do we design and deliver our services so that they are accessible, inclusive, low threshold, high fidelity, they hold people in, they're sticky? So
Great,
just a few.
thanks, Carey. Gabe, do you want to come back briefly?
Very quickly, Michael, I forgot it. What should be key in this? It shouldn't be predetermined. It should be going to communities and saying what matters to you, and then what matters to you is where you start from.
Great, thanks very much, colleagues. Prompted by what you said around national kind of leadership, Carey, I'm absolutely kind of with you. And there's something that surprises me, and this is a bit of a personal, so this is not a PHS speaking, but we sometimes describe the health inequalities we've discussed today as Scotland's shame. And I think that feels right. That's the right language, given the extent of them. And for me, sometimes, and I've got part of this because I'm a kind of leader in these systems, I wonder why it's not the subject of more kind of national political debate about the extent of those health inequalities. So that's, again, something in Public Health Scotland we're trying to kind of make the case for. So, brilliant. Thank you very much, colleagues. So we're coming to the wind up now, colleagues. And what I want to do is give each of the panel in turn the opportunity to give their kind of key messages. We've maybe heard a bit of that already, but if you want to say anything more, Donna, I'll ask you to go first, because I think you've already said that you might have a slide or two to share, and then I'll come to Carey and then Gabe, and then we'll wind up and get finished on time, if that's all right. Donna, over to you.
Yeah, that's great. This is the inspiring work that they're doing in Changing Futures Northumbria. Absolutely amazing work, and if anybody's interested in finding out more about it, there's loads of podcasts and interviews with this brilliant guy, Mark Smith, who's the Director of Public Service Reform at the Council. But this is just to answer the question that the person asked in the chat about the evidence base for investment in the community and voluntary sector, and in a different type of model. An investment in something that's not reactive, that is proactive, that's preventative, that's community-based, that is social, as well as being medical. So I'm just going to show you a few slides, Mark, if you can put up the first slide. This is a guy called John, not his real name, he's a resident of Gateshead. And this is his journey through public services over a 10-year period. So this is the ambulance call out and acute system response to John. All separate, all siloed. He was going into A&E more or less every day, accessing mental health support more or less every day. Nobody was helping him. It was all assessing him against eligibility criteria. He was being arrested on a regular basis. Again, no one actually working out why that was and what the root of the cause of that was. And the overall cost was £2 million for one individual in public services in Gateshead. This is the evidence base about why we need to change. This is where all our money's going. So people say we need to make savings. You know, don't cut the voluntary sector, cut that ridiculous way of organising public services. And also more heartbreaking than anything is all those opportunities to help him that we missed, to really help him by building a relationship with him. And what the liberated method does in Gateshead is frees up frontline teams of people to work differently and support people in different ways. Go in, help them clean the house up. You might think that's not the role of a public servant. Well, yeah, if it helps him regain his sense of perspective and pride, then go in and clean the house up. Go with him to do some shopping, help him with his budgeting, help him, support him in a different way. And that's why, you know, often need doesn't fall within a neat service category that's a commissioned service. Need is social. Brilliant, thank you.
Thanks, Donna, really powerful. Carey, your takeaway.
Thank you. I probably said quite a lot of it, but I guess it's just about maximising the role of healthcare to address health inequalities by meaningfully addressing the inverse care law, which has now been around for more than 50 years and is not getting any better, where access to care is poorest for those that are most in need, and we see people missing within our systems. So people who serially don't turn up to appointments, don't make use of healthcare, particularly if they have a mental health diagnosis, have a huge increase in their rates of early death. So the people that we're not seeing and not hearing from are the people that we should be most worried about, but our systems are not designed to search them out and support them. So I think it's just thinking about the inverse care law, about missingness, about maximising the ability of how we design and deliver our systems to address health inequalities, and genuinely shifting that balance of care out of the most expensive part of the NHS, which is A&E and hospitals, out into the community, so that we can start to more meaningfully build resilience within community-based settings, not just within health, but with our communities and with our voluntary organisations, so that we can create a different kind of healthcare that feels more socially inclusive, that has more time within it to build relationships of trust and support well-being and enable a different kind of conversation, and one that is much more proactive and more kind and socially orientated.
Thanks, Carey, much appreciated. And last but not least, Gabe.
Michael, you started with the data about healthy life expectancy. I've been 44. One of my colleagues led a homeless needs assessment in Lanarkshire a few years ago, and actually life expectancy of people who were chaotic homeless, I apologise for using the term, was actually less than that. We're almost actually in Victorian times, you know, of life expectancy, basically. So that's just a wee take home from there. Quote Andrew Fraser, inequalities are unjust and avoidable. You know, that's number one, basically. We need to go for industrial dosages in terms of the response. We've got to get away from the short-term pilot, do this basically from there. I would really beg for actually economic evaluation going alongside it, basically, because I actually think we could actually show really quite clearly, you know, what the contribution is to society by actually doing this work. And then the last bit, it's got to be sustained. We've got to get out of this cyclical change, you know, and difference of a, you know, kind of like policy or new projects or whatever. I'll stop there.
Great, Gabe, thanks very much indeed. Colleagues, I'm really conscious of time. We're almost out of time. I want to say thanks particularly to the panel, to Carey, to Donna and to Gabe. for sharing their thoughts with us today so eloquently. Thanks again to Susan, and apologies to Susan that we weren't able to bring in Susan. I'm really, really sorry that that didn't work out for us and for you. It's our kind of loss, so apologies again. And thanks to everybody who's joined. Thanks to the team in PHS who set this up. The one request, colleagues, is we hopefully posting or have posted a link to an evaluation in the chat. If you could complete the evaluation, that would be really helpful in ensuring we understand how this was for you today, but how we can better shape such experiences going forward. So with that, colleagues, I'll let you get back to the rest of your day. Thank you very much indeed. It's been a really thought-provoking, but hopefully energising session about tackling health inequalities. Thank you.